To kick things off, I just want to welcome you all to our presentation this evening, Neurology and the Role of the Speech-Language Pathologist, Part 2, with our guest expert, Anna Swindle. I am super excited to have Anna back with us for Part 2. A couple of housekeeping items. This webinar is eligible for ASHA CEUs. In order to obtain ASHA CEUs, we ask that you complete a brief survey. I will put the link to the survey in the chat. We ask that you complete the survey by next Thursday, at which point we will submit to ASHA for CEU information. I know a lot of people are logging in on their iPhones after work, so if you can't access the chat, no worries. It will be sent out via email from Zoom at the conclusion of this presentation. Additionally, if you would like a certificate of completion, please send us an email at tims-univ@tims.com and we will get that to you within 7 days. And finally, there will be a lot of information in the presentation this evening. So if you want to go back and rewatch any of it, the replay will be on our website within 48 hours. And Anna has provided a handout for all attendees to download, which again will be sent out via email from Zoom. If you missed any of this information or have questions about the content throughout the evening, please put your comments in the chat or the Q&A, and we will answer those as they come in and during the Q&A at the end of this presentation. With that, I will hand over the floor to Anna.
Awesome. Thanks, Brooke. Well, thank you for having me back. I enjoyed this last time, and I'm excited to kind of expand on everything we covered in part one. So today, we'll kind of recap on part one. So I hope that you've watched that, and if not, it might be beneficial to kind of revisit it after you see this one. I go over a lot of foundational stuff. So just keep that in mind as you're going through here. If I kind of go through something quickly, it might be useful to revisit the first one. Disclosures. I do receive payment from Tim's University for this presentation. I'm employed as an SLP in acute care at Emory Healthcare in Atlanta, Georgia, and it is not at all affiliated with this presentation. I'm a member of ASHA. I'm a certified brain injury specialist through the Brain Injury Association of America. I have a certificate in neuroscience through Duke University. I got that online through Coursera. And then, of course, I'm a user of Tim's equipment. We use it at my hospital for both modified barium swallow studies and fees, and love it. That's great. So like I said, let's recap a little bit on part one. You're going to recognize some of the images that you'll see in the next few slides. But, of course, neurology is kind of a beast of a topic. So I wanted to kind of go over some foundational information before we hop into, more kind of detailed things. So in part one, we covered a lot. We went over, the nervous system, different terms, parts of the central nervous system, the peripheral nervous system, like tracts and nerves. We talked about the cranial nerve exam and the importance of kind of that in our role as diagnosticians. And we talked about upper motor neuron injury versus lower motor neuron injury and kind of how that manifests clinically. We talked briefly about kind of what I like to call the cranial motor pathway, understanding, what drives the motor processes of speech, voice, and swallowing. And again, our role as diagnosticians, kind of knowing all the different subparts of that pathway and kind of figuring out maybe where the breakdown might be occurring. So again, let's get into the cranial motor pathway. So when we talk about this, we're kind of talking about, again, the sequence of when we think about initiating movement of speech, voice, and swallowing. So we have our pyramidal tracts, the cortical bulbar tract and the cortical spinal tract. They begin in the precentral gyrus, the motor strip of the frontal lobe and the cortex, and they descend. The subcortical tracts then descend as the internal capsule. They might be referred to as several different things, kind of depending on the location of where they are once they descend. So you might see words in imaging like corona radiata, centrum semiovale, periventricular white matter, or cerebral peduncles. So any of these terms are referring to the axons, the motor tracts of our upper motor neurons in the motor strip. And so obviously we're going to be focusing on the cortical bulbar tract because this is the one that communicates directly with the cranial nerve nuclei in the brainstem, or our lower motor neurons, to then move the muscles of the head and the neck and the face. So The neurons of the cortical bulbar tract are the upper motor neurons. The cranial nerve nuclei in the brainstem are our lower motor neurons. And then the actual cranial nerves themselves, those are our peripheral nerves, or the final pathway before that message kind of reaches the muscle to fire or activation for the muscle. So think about the pyramidal tracts. It's kind of, I don't remember if I mentioned this in the first presentation, but think about the pyramidal tracts are the axons of the upper motor neurons. And so we'll revisit this later, but that is kind of the most simplified way to think about it. So the first kind of part of this sequence, we got the upper motor neurons and their tracts again. So that blue, the spot that's highlighted in blue, that's your frontal lobe, your motor strip, your motor homunculus, as you might know it. So the red that kind of sprout out from that, those are your subcortical tracts. Those are your pyramidal tracts, your corticospinal and your cortical bulbar tracts. The cortical bulbar tracts will, because they're innervating the muscles of the head and the neck, they kind of synapse at the lower motor neuron, depending on their respective lower motor neurons in the brainstem, the cranial nerve nuclei. Whereas the muscles of the trunk, the limbs, the extremities, those are innervated by the corticospinal tract, and that will then continue to descend on into the spinal cord. And again, that little star in the picture on the right, that is kind of showing you right at the medullary cervical, where they kind of meet, cervical spine and the medulla. That is where the corticospinal tract decussates or crosses, and that is why we see contralateral impairment when somebody has a cortical stroke or cortical insult. So you can think of the upper motor neurons as kind of like the first order neurons, and then we've got those subcortical tracts that send that message, and then the cranial nerve nuclei are like the second order neurons. So our motor nuclei are our clusters of cells or gray matter neurons that kind of sprout and grow out the efferent or the motor fibers, the axons that make up the cranial nerves to then innervate the muscles of the head and the neck. So again, I know we're going to talk about this a lot just because I feel like reinforcement kind of makes things stick. Upper motor neurons, they send this electrical message via the tracts, the internal capsule, corona radiata, the pyramidal tracts, to the lower motor neurons in the brainstem. Those lower motor neurons then send the message via the cranial nerves and then out to the muscles to then generate the movement. Sensory nuclei are also housed in the brainstem. And these are similar to motor neurons. They're clusters of cells or gray matter that receive sensory information via the afferent fibers or the axons of the cranial nerves that have sensory branches. So our something like the facial nerve has a sensory branch. If it's picking up information and kind of ascending that information up to the cortex and to the parietal cortex, so it can then be kind of synthesized. So we have the nerve to the nuclei through the thalamus and then up to the parietal cortex where it's kind of interpreted. Most cranial nerves connect to one or two of the nuclei in the brainstem, and this is where it gets, well, it's all tricky, but this is where, in my opinion, it gets really tricky because it would be a little more easy to understand if it were, the facial motor nerve of the facial nerve only connects to the facial motor nucleus and the pons, but that is not how it's not that simple, because that would be too easy and too logical. So, for example, the nucleus of the solitary tract, the nucleus solitarius in the medulla, it has connections to the facial nerve. It has connections to the glossopharyngeal nerve, the vagus nerve. So that's kind of where it gets tricky. And I'll show you a picture in a few slides to kind of visualize it better. And then as a reminder, in the brainstem, when we have these cranial nerve nuclei, the sensory and the motor nuclei, they're all paired. So there's two of each, one on each side. And there's some have sensory function, some have motor, some connect to nerves that have both. So revisiting this picture we went over in part one, when we say, again, both sides have both, but just for the purpose of understanding, you see the blue is the sensory nuclei and the red are the motor nuclei. When we say lower motor neuron damage, this is what we're talking about. So if somebody has compromise to, if you look at the, sort of the midbrain, the pons, and the medulla, if you look there in the middle where the pons is, you can see that's where the facial motor nucleus is, trigeminal motor nucleus, the abducens. So if we, how we use this clinically, if we are chart reviewing for a new evaluation and the imaging report says, something like infarct in the medial pons, well, then maybe we should be kind of hypothesizing, maybe we'll see some like a hemifacial involvement, hemifacial droop, maybe some, ocular involvement if the abducens nerve or the abducens nucleus and thus the nerve can't communicate with the muscles. Maybe we'll see like some a disconjugate gaze, strabismus, inability to like lateralize the eye. So I think just kind of obviously not knowing not remembering every single one, but kind of having a visual like this to kind of revisit can definitely be useful. And I like this image. So we're talking about kind of the last part of the pathway, the actual nerve, where that message then connects. That's how we get the message to the muscle itself. And I like this image because you can kind of see that, if you have like a lateral view of the brainstem there, they don't have the sensory nuclei here, but the motor nuclei, you can see that they kind of like sprout out the the um, the nerves, and so that's kind of how we think of it as the cranial nerves are the axons of the lower motor neurons, and so we talked about too the pyramidal tracts, the cortical bulbar fibers, are the axons of the upper motor neurons. So you can see there's like the clusters of neurons, those are the nuclei. And then you can see, like, for example, if you look at the nucleus ambiguous in the medulla, one that's very important for us to be familiar with, that it kind of like sprouts out the glossopharyngeal, cranial nerve 9, the vagus, cranial nerve 10, and then the spinal accessory, cranial nerve 11. So it has these connections to more than just one cranial nerve. So kind of synthesizing all of that, if we think about the cranial motor pathway, the first kind of part of that is that signal is generated by the upper motor neurons in the motor strip or the precentral gyrus. That signal is then sent along the axons of the upper motor neurons via the internal capsule, or you might see it in imaging, corona radiata, periventricular white matter, centrum semiovale, and that is where the cortical bulbar tract is housed. So keeping in mind the innervation of the muscles of the head and the neck. And then from those descending subcortical tracts, they pass through the midbrain, where they become the kind of the cerebral peduncles. So they kind of like get a little bit more narrow because we're trying to kind of push them all into the brainstem. And then the signal synapse at the whatever respective cranial nerve nuclei in the brainstem. And then from there, the motor signal is then sent via the efferent or motor branches of the cranial nerves that kind of sprout or emerge from those cranial nerve nuclei. So it's a very obviously complex process that happens, in a very quickly, and breakdown anywhere in this process will manifest as what we see as potentially cranial nerve impairment or weakness. And so, the process here it's super complex, and it starts, as this electrical signal in the motor strip. And then after this whole pathway, it then converts into a chemical signal and out to the peripheral nervous system through the nerves. And so we have subcortical tracts, we've got upper motor neurons, we've got lower motor neurons, we've got the central nervous system, the peripheral nervous system, we've got electrical, chemical processes happening. So this is very, very complex, and we'll get into what it kind of looks like clinically when somewhere in this, sequence of events, something breaks down. So let's again revisit the cranial nerve exam. And so to kind of review the purposes of, the speech pathologist role in terms of um, giving a cranial nerve exam is it's part of a comprehensive swallow evaluation, or speech and, voice evaluation. Uh, Understanding, the whole diagnostic picture, or maybe just maintenance. So, every time I see a patient in the acute care setting, every time, not just on evaluation, I will do a quick repeat cranial nerve exam. I mean, because it takes max 4 minutes. And so if you do that, then maybe you might miss, you may not, you'll be able to catch something that maybe somebody else hasn't because it's subtle, or it's a change, there's a sign of some type of change or in status, or like somebody that had a um you know subarachnoid hemorrhage, for example, in the ICU, and they're, got the neuro monitoring and the neuro checks, and you see them one day and then you see them the next day and they've got a different presentation in terms of the cranial nerve exam that might indicate that their bleed is evolving or expanding. So it's less about mapping suspected, like, if I see this in a cranial nerve exam, what does that mean for my treatment plan? And more so about the usefulness in our assessment and kind of our role as diagnosticians in the whole diagnostic process. So understanding, in acute care, my focus is really swallowing, and so understanding the integrity of the sensory motor system that drives swallow function, and of course speech and voice as well, because those are also complex sensory motor processes too. So, for example, if I do an evaluation and I feel that, the cranial nerve exam was significant for something, that can serve as data. It's data that we can kind of give the medical team to aid in differential diagnosis. So, for example, if I see somebody and I'm shooting the physician, the hospitalist, a message: "Hi, Dr. Patel. I just evaluated Mr. Smith. Cranial nerve exam was significant for a left hemifacial droop, concerning for involvement of the left facial nerve itself and or the lower motor neurons or the facial motor nucleus in the left brainstem pons. I see an MRI with and without an MRI brain with and without contrast is ordered. It may be useful to ask for specific attention to the brainstem for optimal assessment." Copied the neurologist on this message as well. Thanks. And so, not only in acute care, in every setting, this interdisciplinary communication is crucial. But specifically in maybe an inpatient setting, you have a little bit more access to the medical team, and that's something that can be really helpful. And so in this example, if you're seeing something like this and you see, okay, an MRI brain is ordered, good. Particularly the brainstem, which we'll talk about when we talk about case application, it's dense. It's full of a lot of tracts, pathways, nuclei. So it's a little bit harder to catch, especially smaller things on MRIs. And so I've seen sometimes if a neurologist, is concerned for some pathology localized to the brainstem, they might order, like they might actually put in their order, specific amount of slices to the brainstem, or a specific attention to the area of the facial nerve or something. So I thought, that would be a good example of where that could be useful in kind of that differential diagnosis. So we also talked about in part one, when we say cranial nerve exam, clearly with what we just talked about, break down anywhere in that cranial motor pathway. We've got the upper motor neurons, the lower motor neurons, the subcortical tracts, the nerves, the neuromuscular junction. So, two completely different nervous systems. So anywhere in that pathway, if there's a breakdown, it can lead to what we see clinically as an atypical cranial nerve exam. So perhaps what might be better to kind of capture what we're really looking at, is it more like a cranial sensory motor exam? Because if we see, like for the last example, a hemifacial droop, yes, that could be a nerve impairment. But what if it's a stroke right in the facial motor nucleus in the brainstem. Well, the nerve is intact, but now it's not getting that input from its primary nucleus. So think about that going forward. When we do a cranial nerve exam, that we're assessing the integrity of that entire pathway, that entire sequence, and all of the kind of subparts of that sequence. And specifically in swallowing, it's one of the most complex, routine actions that the body does. There's 26, at least 26 paired muscles, at least 5 paired cranial nerves. We got, again, the cortex, the subcortex, the brainstem. So when we're doing cranial nerve exams, particularly as part of a swallowing assessment, that's something to keep in mind, that we're assessing the integrity of this entire system. So back to the cranial motor pathway, when we talk about, again, where's the breakdown in this pathway? Let's say that in a note, this is what we write up. Cranial nerve exam revealed a left lower or central facial droop, only the muscles of the lower left facial quadrant with reduced movement, the flattened nasolabial fold, but the movement of the forehead is symmetric and bilaterally. So we're seeing it's intact, it's preserved. So in this particular case, the etiology was an ischemic stroke of the right frontal lobe. So damage of the first order neurons, the right upper motor neurons, that first part of that pathway. So the upper motor neurons that communicate with the cortical bulbar fibers that then descend and synapse at the facial nucleus to then get the message out to the cranial nerve 7. So are the cranial nerves damaged? No. The cranial nerve is intact, but they're now receiving less input from the cortex, from the upper motor neurons. So one of the, again, talked about this in part 1 a little bit more in detail, but when we think about innervation, the lower part of the facial motor nucleus only receives kind of that electrical innervation from the contralateral hemisphere, whereas the top part of the nucleus, which is the motor neurons of the upper facial muscles, receives bilateral cortical input. So if we have a unilateral cortical stroke that takes out either the upper motor neurons or those tracts that communicate with the lower motor neurons, we take out the whole ability to get the message from the upper motor neurons, and we don't have any fail-safe. We don't have any input coming from the other hemisphere to kind of compensate for that. So that's why we see in a unilateral cortical stroke, that's why oftentimes we're looking for, is there a unilateral central facial droop? So for this one, cranial nerve exam revealed a left hemifacial droop. In other words, both upper and lower facial quadrants on the left side of the face with reduced or limited movement. And the etiology in this one is an ischemic stroke in the left pons, so our lower motor neurons. So the structures that are impacted here are the left lower motor neurons of the facial motor nucleus. And are the cranial nerves damaged? Again, no. The facial motor nerves are completely intact, but now they're receiving little to no input from their cell bodies or their nuclei. So if you envision that picture with the kind of how they're sprouting out from it, they're not able to get that message from their motor neurons. So the axons that make up the cranial nerves can't send the message then to the facial muscles. So maybe in assessment tasks, you observe ptosis on the left or eye drooping, inability to close the left eye, or if you're doing the intraoral pressure tasks where you have them, puff up your cheeks with air, and you see that they can't get a good labial seal on the left and the air is escaping, perhaps that's maybe what would lead you to kind of synthesize this is a left hemifacial droop, not just the lower quadrant. And then cranial nerve exam revealed a left hemifacial droop, again, both upper and lower facial quadrants on the left side of the face with no movement or no evidence of activation, and ptosis of the left eye. So in this case, the etiology here is Bell's palsy, which is essentially like a hyperimmune reaction to typically a viral infection at the level of the actual uh, facial cranial nerve. So what we usually see is a hemifacial droop or hemifacial involvement. So the structures that are impacted here are the actual nerve, the facial nerve, the motor branch, or the last part of that craniomotor pathway before the message gets to the muscle or the neuromuscular junction. So here, are the cranial nerves damaged? Yes. Even if the motor neurons, the white matter tracts are cortical bulbar tracts, and the lower motor neurons are intact, now the nerve can't receive the signals. And so that's why we see the left hemifacial droop here. So all of that to kind of illustrate an abnormal cranial nerve exam may not be a cranial nerve impairment. Um, and that's just something to kind of think about because oftentimes when we're doing these, of course, we're doing them for to kind of guide our decision making and hypotheses about swallowing and swallowing impairments and for people that have had insults that are of different etiologies, whether it's cortical, brainstem, what have you, a lot of this can often give useful information about treatment. So, for example, if somebody comes in with a hemifacial droop and no other sensory or motor impairments, and they tell the physician, I just got over, a cold, or I just got a vaccine or something, that might prompt them to say, yeah, this is probably more likely a Bell's palsy and less likely a central process like a stroke. So, with that, before we move on to stroke, let's kind of remember to simplify as much as we can that the pyramidal tracts are the axons of the upper motor neurons. The cranial nerves are the axons of the lower motor neurons. And then the cortex kind of serves as the operator of the whole system. It hits the start button, it controls the settings, it modulates and refines kind of how much power or force we're giving. Because, when you think about it, the pyramidal tracts, technically, we're talking really only about the voluntary movement. And that's, beyond this presentation, we have extrapyramidal tracts that kind of contribute to involuntary movement, tone, etc. But the whole process has to start with the cortex. The cortex is the operator of the system. And when we think about the motor processes of speech, production, voicing, and swallowing, all these things have to be operating. So we're gonna again get into primarily stroke is what we'll start out with, and we'll talk about some neuromuscular processes. Before we get into, I know we touched on this in part one, but kind of thinking about, I know most of us know strokes, can be ischemic, hemorrhagic. There can be lots of different like sources of why somebody has a stroke. And it can be cardiac, like a PFO, it can be cardioembolic, like AFib, or heart arrhythmias, where the rate is off, and so it can lead to like pooling and blood clots. You can have like arterial dissection, where there's direct damage to the artery, and so we can have like tears that can then break off and kind of embolize. You can have atherosclerosis, or just kind of that fatty plaque buildup of arteries, and that can lead to narrowing, and then sometimes thrombosis or emboli. You can have like hypercoagulable states I've seen clinically. So if somebody has, like metastatic cancer, that might put them into like a hypercoagulable state where they're more prone to clots. I've also seen like septic emboli. So if somebody has sepsis, some type of bacterial infection that's advanced to the point where it's reached the blood and, they're in the ICU, you can have like bacteria, fibrin, and like platelets kind of break off from an infected site, usually like a cardiac site, and travel through the blood and then embolize and potentially lead to a ischemic stroke. So lots of ways that we get there. But for the purpose of kind of keeping things simple, let's think about we got ischemic strokes where there's for some reason, like we just talked about and went through, that they're the we can't oxygenate. The arteries can't oxygenate that tissue, and so that leads to ischemia, and then so there's reduced blood flow, reduced oxygenation to that tissue, and then as a result, an infarct. And then, of course, you can have the opposite, where it's more of a like a hemorrhagic issue, where there's like a burst or an aneurysm, or some type of vascular issue that leads to blood in the brain, like a subarachnoid hemorrhage. So we'll talk about cortical strokes, meaning strokes that occur somewhere in the cortex. So I'll talk about some examples, but in these cortical strokes, we will commonly see like cortical signs. So like our aphasias, visual impairments, cognitive impairments, alexia, or trouble with reading comprehension, agraphia, trouble with written production, apraxia, motor planning impairment, visual inattentions or neglect. So those are kind of our cortical signs. And then, of course, we can also see sensory and motor impairments like dysphagia and dysarthria, paresthesias and numbness, tingling, that kind of thing. But the things listed there and on those bullets, those are our primary cortical signs. So if somebody comes into the emergency department and they have, sensory and motor impairment paired with a true aphasia, then that might lead the attending to say, this might be a cortical stroke. This is like a cortical stroke. And so again, motor and sensory impairment will also be seen in, subcortical and brainstem strokes, but we will see those things in conjunction with those cortical signs. So what kind of terms in imaging, somebody has CT head or MRI brain, what kind of terms in imaging are we looking for that might indicate that this is a cortical stroke? So things like precentral gyrus, anterior temporal lobe, or frontoparietal area, or lateral parieto-occipital junction. So think about the cortex and the lobes and kind of the cortical markers that might indicate this is a cortical insult. So, for example, if we look at an MRI brain and it says region of hyperintensity and diffuse restriction in the posterior left temporal parietal lobe, and our kind of clinical assessment is here, the cranial nerve exam was unremarkable, was normal. That's because if you think about where the kind of posterior temporal parietal lobe is, we're further away from the motor strip and further away from those descending subcortical motor tracts. So they're preserved, they're spared. During conversation, patient has fluent output, but it's mostly characterized by jargon, paraphasias, intermittent anomia with periods of correct, effective verbal output. So fluent, but not really efficient, effective, with some kind of, it sounds like some instances where it's appropriate. Unable to decode and comprehend written words, phrases, or familiar written stimuli. So and alexia, trouble with reading comprehension. And then generating written words, but spelling is inaccurate, with frequent letter substitutions, letter omissions and additions, and poor sound letter recognition. So in other words, that's an agraphia. So, in this case, what other things might be part of the clinical picture? Based on this, we're presuming that the motor cortex and the frontal lobe and the subcortical tracts, so the corticospinal and the cortical bulbar tracts, are preserved. This might be a case where the patient is walking and mobilizing well, and they don't have any fine motor concerns. They do great with PT and OT, but their primary concern is aphasia, or like a linguistic deficit that we know can have um, remarkable impact on function. And the other thing I wanted to mention here, um, just when we think about MRI brains, when now I don't like, you know, even pretend like I can interpret them, but I do know kind of some like trigger words where just to kind of better understand when we're chart reviewing, when we see hyper intensity, if when physicians order MRIs and when radiologists interpret them, they get like different kind of sequences. Um, I don't. There's probably a better way to describe it, but sometimes they get like ADC sequences and the other ones DWI. I think it stands for like diffuse weighted something. Um, when we see those in a ischemic, when we see an ischemic infarct in a MRI brain, it will show up. An acute ischemic infarct will show up as a hyperintensity. So if you ever like pulled up the imaging and looked at it in on a DWI image, that hyperintensity and infarct will be like bright white. Um, and just something to kind of keep in mind. Sometimes I think it's cool to kind of see it. Subcortical strokes. So, below the cortex, we'll commonly see more motor impairments. And we know now why, because if those cortical structures are intact, where all of the conscious, cognitive, higher, order processing happens, but we take out some of those cortical bulbar, cortical spinal descending motor tracts, then maybe they'll be walking, I mean, they'll be talking okay and no cognitive impairment, no aphasia, but they might have a motor impairment. So like a hemiparesis or like a unilateral weakness, dysarthria, dysphagia, potentially some sensory impairments, and other cortical signs, like we talked about, the aphasias, cognitive impairment, visual neglect. Of course, they're possible, but they're far less common when we talk about strokes that are isolated to the subcortex. So, for example, you might see in imaging like wording like lacunar stroke or punctate infarct of some region. So when we think about lacunar strokes, these are often the result of like really poorly managed hypertension, diabetes, and those little vessels that kind of branch off of the main arteries are very susceptible to damage from that. So that's what that means when there's a lacunar stroke. It's not like the primary cerebral arteries, but the small like vessels that branch off of it. And those are what supply primarily the subcortical tracts that we talked about, and we talked about the motor pathway. You might also see these labeled as like pure strokes or pure syndromes. So like a pure motor stroke or a pure sensory stroke, so for in the event of like a pure motor stroke, we got like lateralized weakness affecting the face, the arm, and the leg on one side, but sensations intact, no sensory loss, no vision changes, no cortical signs like cognitive changes or neglect. So it's purely isolated to motor function. And then also in contrast, if you see something like a pure sensory stroke, maybe somebody comes in with, paresthesias, numbness, tingling, affecting, the right face, the right upper extremity. And then if it's kind of lateralized like that, that might be pointing more towards a pure sensory stroke, like maybe a thalamic stroke. So subcortical structures to keep in mind when we think about what parts of the brain might be impacted by these subcortical strokes, the basal ganglia. So if you see wording and imaging like the putamen, the caudate nucleus, the globus pallidus, the striatum, those are all different kind of parts of our basal ganglia nuclei. And that is a big subcortical structure. Again, the thalamus, so our sensory relay center, we got one on each side. And the thalamus are made up of a lot of little nuclei. But kind of generally speaking, I've seen if somebody comes in to the hospital and they have, a right, like they say something like, yeah, the right side of my face has been kind of numb. I feel like I'm biting my tongue. I can't feel it very well. And then I've had some on and off numbness in my right hand. They may have had like a left thalamic stroke, so that thalamus isn't able to relay that sensory information up to the parietal cortex where it's then synthesized. Again, our motor tracts contain the cortical bulbar and the cortical spinal tracts. So the internal capsule, corona radiata, centrum semiovale, periventricular white matter, and our cerebral peduncles. So, and again, this is, it has to be complex because if, it has to be hard. That these are all different terms for our descending white matter tracts. So when we think about the pyramidal tracts, the subcortical tracts that communicate with the upper motor neurons. So let's see an example for a subcortical stroke with our SLP assessment, like what we might see clinically. The MRI brain says small acute area of restricted diffusion in the left corona radiata, consistent with an acute ischemic infarct. So our cranial nerve exam, we see the patient, we document that our cranial nerve exam is significant for a right central lower facial droop. So the upper facial quadrants are intact, they're moving well symmetrically. And a rightward lingual deviation. And this is concerning for a central process affecting the upper motor neurons / motor tracts, because you can't know based on that presentation, of cranial nerves 7 and 12. And that is consistent with the lesion location on imaging. Because this is a subcortical stroke, we don't have those, in this case, we don't have those cortical signs. So they're cognitively intact, they're oriented, they're following multi-step commands, they don't have any difficulty, recalling all the details of the past few days and their conversations with medical providers. Verbal output's fluent, it's appropriate. You don't notice any obvious cognitive linguistic concerns. And then maybe you notice a mild articulatory impairment, most consistent with a unilateral upper motor neuron dysarthria. So what other motor findings, this is kind of like what we see as speech pathologists, but what other motor findings might we see in somebody that has a left corona radiata or a left subcortical motor tract impairment? Perhaps we see a right upper extremity weakness, right lower extremity weakness. So if somebody, and we'll get into this in a few minutes, but if somebody comes in with weakness on the lower part of the face and on the same side of the body, they have weakness in their extremities, then we're thinking that is likely a cortical process that's happening. Brainstem strokes, the big guns. So the brainstem is, if you think about it, if you just visualize it, you've got the brain, the brainstem, and then the spinal cord and the rest of the body. It's kind of the road that connects the central nervous system and the peripheral nervous system. So, all information that has to go to and from the central nervous system to the peripheral nervous system and vice versa is going through the brainstem. And like we kind of mentioned earlier, it's very densely packed. There's a lot of important pathways, nuclei, tracts that run through here. So we can see some, if somebody has a brainstem stroke or a brainstem tumor or some type of compromise to the brainstem, we can see some pretty catastrophic impairment. We'll likely see motor and sensory impairments because if you think about, again, what we talked about with the sensory nuclei, the motor nuclei, all information that's coming from the afferent sensory branches and going up to the cortex to be synthesized is going to the brainstem. Specific deficits, and this is what's so interesting about the brainstem, what I've seen clinically is, of course, just like any other stroke, specific deficits will obviously depend on, blood supply, the etiology, the nature, why it happened, how big was it ischemia, was it, but there's a lot of variability. And so if somebody, I've seen somebody that has a stroke in the pons that just just misses all of the important things. So maybe they come in, I mean, everything's important, but in terms of our swallowing speech voice assessment, we don't see any hemifacial droop. We don't have any dysarthria. We don't have any concern for dysphagia. Potentially, it may be just, maybe it was here. It just missed, it missed the, those important structures. So there's a lot of variability, what I've seen clinically in brainstem involvement. And then I also want to touch on cognitive impairment. So when we think about the brainstem, I mean, there's no really conscious processing, cognitive processing that happens in the brainstem. So, the like higher level cognitive processing, that's a cortical function that's happening in the cortex. But we do have a lot of important structures like the reticular formation and nuclei and tracts that connect to the thalamus that play a really big important role in attention and vigilance and wakefulness. So we may not necessarily see like cortical signs, aphasia, cognitive impairment from a cortical perspective, but maybe we'll see like disorders of consciousness. People that can't maintain alertness or they're really lethargic or that like vigilance is off. So cognitive impairment, maybe not so much in terms of what we think of it as cognitive impairment, like memory and attention and executive function, that kind of stuff, but maybe more so the foundational things that kind of have to be intact for the underlying the foundation of cognition. So again, like the consciousness is what we think about when we think about potential cognitive impairment with brainstem involvement. And obviously, again, we can see why that would be a catastrophic functional impairment. If you've ever seen a patient with disorder of consciousness, that impaired consciousness will then domino effect and affect everything else too. So brainstem stroke, and I wanted to kind of highlight again the variability that we can see. So if somebody has a brainstem stroke and then versus a brainstem mass. So let's say that a brainstem stroke, we see the MRI brain, small punctate area of restricted diffusion within the left ventral pons, approximately 3 millimeters in greatest dimension. So, I mean, that's really small. The infarct was just lateral to the facial motor nucleus, so it's spared. We don't have any overt hemifacial weakness. Maybe it's affecting some input from the left cortical spinal tract to the right body, because remember that cortical spinal tract will then decussate across right at the kind of cervical medullary junction. So maybe the patient has some mild right upper extremity weakness. But when you think about functionally, like the NIH score, is probably relatively low, right? Because this is a small stroke that kind of just missed some of the really important structures. Whereas if we see another patient, their MRI brain says large expansal mass centered in the right pons, highly suspicious for an aggressive pontine glioma. Well, what if this mass is compressing the right facial motor nucleus, the right trigeminal motor nucleus, and that's causing ipsilateral paralysis of the right face? So then we see the upper and lower involvement lateralized to the right, inability to elevate the jaw, close the mouth, significant left hemiparesis of the body. So in that example, again, that would be what's referred to as crossed hemiparesis. So if somebody comes into the hospital, they've got a left facial droop, but right-sided weakness, that should automatically kind of cue you in to be looking at a process in the brainstem. So that would be crossed hemiparesis. So let's get into a case. This is a person I saw a while ago in the ICU. So I don't remember all of the details, but it was a very interesting case where it kind of highlighted the critical functions of the brainstem and kind of functionally what do we see when those are compromised. So this is a brainstem stroke. This is not the patient's actual MRI. It's just something I found online, but we can pretend. So the patient was admitted to the hospital with quickly progressing weakness in all four extremities. A code stroke immediately called, CT heads completed. The CT is significant for a large hemorrhage in the central pons, extending bilaterally to the left and right. The MRI brain also shows surrounding pontine infarcts or ischemia and edema or swelling. So we got a lot going on in the pons. Neurosurgery evaluates the patient, but does not recommend surgical intervention unless that edema starts to compress other structures that would potentially lead to like more life-threatening conditions, like if the ventricles are compressed and they can't, you know, the cerebrospinal fluid can't get through, or the patient's admitted to the ICU for close neuro monitoring. So maybe some like hourly neuro checks and, you know, repeat head CT in 24 hours, you know, all the things that are kind of closely monitored for potential shift or change. And I believe in this case, the neurosurgeon, when we think about like neurosurgery, obviously any surgical intervention is a big deal. But in this case, his rationale was surgical intervention. There was more risk to it than the potential benefit, especially when you think about like brainstem neurosurgery with the brainstem. You're working with a very fragile area. And so there's often a lot of secondary complications that can happen if that area is operated on. So in this case, they said let's monitor the patient and kind of see what happens. You know, in the event that that patient got hydrocephalus or something, then potentially they would have reconsidered. So the chart review, let's say our assessment, the chart review mentions. So I actually remember very well this patient because I was going through the chart, and I like to kind of like, this is so nerdy, but I kind of like to like hypothesize, what, especially if like the imaging isn't in yet, like what might this be? And one of the first notes from the ED provider, I don't remember like what their role was, but said the patient's aphasic. And I thought, because at this point, I think I had seen the imaging. I thought, aphasia is a cortical sign, and this patient just had a massive brainstem insult. So, no, probably not. Some lethargy, but overall quite alert, despite, pontine involvement, especially bilateral pontine involvement. We talked about the reticular formation and kind of the importance of those tracts that kind of connect with the thalamus and the basal ganglia, and then they contribute to the alertness and wakefulness. But this patient was somewhat lethargic, but really quite alert. Was unable to move his arms or legs. He only had some slight reflexes present per the neurology note. When I saw the patient, the cranial nerve exam revealed flaccid orofacial musculature globally or bilaterally. Bilateral involvement of cranial nerve 7 or the cranial nerve, the facial motor nuclei. Very limited movement of the forehead was noted when I was like cracking jokes, and I could see that like the more involuntary like facial expressions, there was very limited movement on the forehead. Unable to protrude or lateralize the tongue, so that's cranial nerve 12, the hypoglossal nerve. Phonate, cranial nerve 10, the vagus nerve, specifically the laryngeal nerve branches, or move and round the lips, so the facial nerve. He is able to move both eyes up and down and inward, but he was not able to move the eyes outward or lateral, and that was likely because of an abducens palsy, because the abducens nuclei are also in the pons. Despite this profound motor impairment, his language function, from what I could glean with the limitations, really appeared intact. He was able to spell out words on a low-tech eye gaze board. He was able to answer yes/no questions with eye gaze or blinking. I'm trying to remember exactly what I did with this patient. I think I got like little communication board with like four quadrants. Um, he was able to identify appropriate icons. He was following multi-step commands with his eyes. So when we go back to that note that says the patient's admitted with aphasia, um, it's not aphasia. This is not aphasia. Swallow function. Following oral care with the suction toothbrush, you provide the patient with a half teaspoon of cold water. You suspect some laryngeal pumping based on what you see, and significant anterior oral loss of the water with very limited oral, lingual, labial movement. You then provide a small ice chip in the patient's posterior lateral sulcus to assess if the swallow can be initiated when the majority of the oral phase is bypassed, but water melts with no evidence of any swallow movement and gradual anterior loss. And ultimately use suction to remove any of the remaining water to prevent aspiration and protect his airway. So what's the reason for this presentation? Well, we have involvement of the bilateral pons. So lower motor neuron or ipsilateral damage to the direct lower motor neurons in the pons on both the left and the right. So, if you look at the picture, again, the blue is the sensory nuclei, the red are the motor nuclei, but they are paired, so each side has both. The left and right trigeminal motor and facial motor nuclei, if you look at where they are in the pons and somebody has a large hemorrhagic stroke with co-occurring ischemia and edema, that's why there's compromise, and that's why there's that presentation of bilateral weakness. Bilateral upper motor neuron type damage to all the nuclei that are below the pons. So the nucleus ambiguous that contains the motor neurons of the vagus nerve, the hypoglossal nucleus that contains the motor neurons of the hypoglossal nerve to move the tongue muscles. If you think about, like, if you look, where all those are here down lower in the medulla, well, if you're not getting any input from bilaterally from the pons, from all the structures that the message that has to descend through the pons to get to the medulla, then you're not going to have that communication with those nuclei below where the insult is. Damage to the descending motor tracts that innervate the extremities via the cortical spinal tract. So again, those tracts decussate at the cervical medulla and they continue on into the spinal cord. So that's why we see that presentation of bilateral extremity weakness. Eye movement was mostly preserved because if you think about the primary, ocular motor neurons, they're here in the brainstem. So we have like the trochlear nucleus, the ocular motor nucleus, and that was spared in this case. So if everything is, the insult is below the level of the midbrain where the primary ocular motor neurons are, they're spared. So is this patient aphasic? No. This patient is nonverbal due to paralysis of the bilateral oral, facial, and laryngeal muscles. In other words, the muscles that produce and manipulate the voice, the energy throughout the vocal tract to then produce speech sound. So this patient is anarthric, and that is not synonymous with aphasic. And, it's like, to me, it's, maybe to other people it's like a little thing, but to me, I think it's important, well, obviously not only to differentiate that clinically, but I remember thinking like this follows somebody in their record, like in another admission or another hospital or another place, a medical provider pulls up this chart and says, oh, the patient's aphasic. As somebody that doesn't specialize like SLPs in aphasia, I've seen that people often assume that people with aphasia are less competent. And something that I told my student I had recently, I'm like, always assume competence in people. Don't speak as if they don't understand you when you're talking to the nurse in the room with them. Always assume that the person is competent. And in this case, he was anarthric. So it was a purely motor process. He did not have cortical aphasia. Very interesting case. And I don't know what ended up happening with him because he transferred to a larger hospital with a neuro ICU, but I think about him often. Case application for our subcortical stroke. Okay, how are we doing on time? Yes, we're good. So let's say our SLP assessment for our swallow function here. And this is somebody I saw recently. And when I saw him, I did not have, like, the MRI brain hadn't been completed yet. And this was my clinical swallow evaluation. Patient admitted with a left facial droop, slurred speech, and dizziness. CT head was negative for acute pathology. The CT angiogram, the head and the neck, so it looks at the arteries, negative for acute pathology or large vessel occlusion. MRI brain and echocardiogram pending to obviously further determine likely a stroke and what was the etiology of the stroke. Neurology evaluated the patient with recommendations for initiation of antiplatelets and a statin. Per the neurology note, NIH-SS score was 3 because of a left central facial droop. So central facial droop, we start automatically thinking cortical or subcortical process. Mild left upper extremity sensory impairment and a mild dysarthria. At the time of this session, the patient's upright in bed, he's breathing comfortably on room air, he's alert and oriented ×4, appropriately answering questions about his stay and following multi-step directions. His speech at the time that I saw him was completely intelligible. I was understanding everything he was saying. Patient endorses ongoing mild weakness in his left upper extremity, which was his dominant hand, unfortunately, and mild sensory changes in his left upper extremity. When asked about possible new swallow changes, he reported feeling the constant need to clear his throat to get mucus out, which I thought was interesting because at the time I was thinking, is it, now like a secretion management impairment or what? He denied history of dysphagia, pneumonia, need for supplemental oxygen, GERD. I mean, he really had a relatively boring medical history, which is a good thing. This date, cranial nerve exam was significant for a left lower central facial droop, concerning for right upper motor neuron or motor tract involvement of cranial nerve 7. With PO trials, appreciated inconsistent throat clearing. Patient is presenting with subtle signs and symptoms of possible pharyngeal dysphagia. Recommend fees in order to objectively assess swallow function, pharyngeal airway protection, and secretion management. And so at this point, because of kind of the things that he was endorsing, that's why I said, let's do a fee so I can actually like look at your secretion management. Patient verbally consented to fees, pending fees, patient appropriate for continuation of regular thin liquid diet with swallow guidelines and oral care regimen in place. So then the fees was ordered. And before we get to the fees, I will also briefly go over his cognitive communication screen or eval. No obvious cognitive communication concerns identified today. Verbal expression, auditory comprehension, short-term recent memory, attention, executive function all appear grossly within normal limits. Patient achieved a 30 out of 30 on the orientation log. His self-generated clock drawing was accurate, and no obvious inattention was appreciated during structured and unstructured tasks. SLP will continue to follow for dysphagia management, no indication for cognitive communication treatment at this time. So I think at this point, based on what I'm reading, is that I was probably thinking if this patient had a right cortical involvement to assess for an inattention or a neglect. And obviously didn't have any concerns for that. Fees revealed mild pharyngeal dysphagia, primarily characterized by slightly reduced UES opening on the left greater than the right, and slightly reduced pharyngeal squeeze. On this study, appreciated trace non-clearing penetration of thin liquids when consumed via sequential straw sips, or a PENAS score of 3. However, when a patient consumed thin liquids via single cup or straw sips, airway protection was intact, meaning there was no airway invasion or he had clearing penetration. So in this case, trace penetration that cleared when he sensed it and initiated a spontaneous swallow, which is a normal response to penetration. Slightly reduced UES dissension led to mild residue at the level of the UES and piriforms, more so on the left than the right, with increased risk for post-swallow or retrograde aspiration, though this was not visualized on this study. Additionally, patients sensate to pharyngeal residue, which is always a good thing, always important to kind of note what their awareness is and their reaction is to residue. To lower risk for aspiration pneumonia, like or aspiration-related complications, recommend adherence to swallow precautions. So I think because, he was in the hospital, wasn't mobilizing as much as he would be. There were some slightly acutely increased risks for things like pneumonia. We just talked about taking single sips. I said if you feel like you have something stuck or hanging out, double swallow, brush your teeth really well while you're here in the event that, because this is just a glimpse of your swallow, in the event that you're guzzling and something, some does kind of enter that upper airway, that supraglottic space, and then potentially descend lower and you aspirate it. Of course, we talked about risk management, which is always important. So looking at his fees, we can see in the first picture, mild pharyngeal residue following a teaspoon of puree, and we use green dye. That's why it's green. The middle picture there, it's kind of hard to see on this image, but you can see some very, very trace, non-clearing penetration after sequential straw sips of thin liquid. So you can kind of see it kind of migrating over from the lateral channels. Then you can also see it kind of migrating over the interarytenoids space there posteriorly. And then at the last picture, this was just an incidental finding. What I guess I described it as a small bulbous beige yellow anomaly in the right supraglottic space, may benefit from ENT follow-up as an outpatient, and discuss this with the hospitalist. So I thought, we were talking after the fees, this patient and I said, you mentioned like you feel like you have this constant need to clear your throat. I wonder if it's because you're sensing sometimes that liquid kind of entering what I call the danger zone, right? Like the upper airway. And maybe that's it. Or maybe you're sensing that residue at the upper esophageal sphincter there that's kind of trying to kind of maybe migrate, and that's why your throat clearing. Or maybe it's this structural anomaly here that you're feeling, and you're sensing like, I feel like I've got to clear my throat, clear my upper airway, potentially because that, lesion, or whatever you want to call it, is kind of stimulating that response, that superior laryngeal nerve, triggering that need to clear the throat. Very interesting. And yes, so let's talk about what the actual MRI said. So his MRI brain with and without contrast said acute infarct noted within the right periventricular / deep white matter and caudate body extending to the right lentiform nucleus. So those are parts of the basal ganglia. Suggested of an MCA lenticulostriate perforator branch infarct. So one of those lacunar infarcts that we mentioned earlier. No acute hemorrhage, midline shift, or herniation. So why would we see in the cranial nerve exam a left lower or central facial droop? Because there was compromise to those subcortical motor tracts, that upper motor neuron presentation. And then again, the cognitive communication evaluation was negative for any obvious changes because there was sparing of the cortex. So when we see the MRI here, we see that everything is kind of isolated to the subcortical deeper white matter. So those pathways that contain the corticospinal and cortical bulbar tracts, which was leading to this presentation. And obviously when he came in, had some dysarthria and some extremity weakness. And so probably compromising some of those cortical bulbar and corticospinal tract fibers. So I was thinking, perhaps on this one, we see slightly reduced pharyngeal and UES efficiency because of compromise to the right subcortical tracts, or the tracts of the upper motor neurons of the vagus nerve, even though the vagus nerve has that bilateral innervation, that has that fail-safe system. It's not like the facial nerve or the hypoglossal nerve. It has, innervation coming from both cortical hemispheres, but it's reduced, so it's certainly possible that even if it's getting some backup, some help from the other hemisphere, that it's not getting as much input. So we can see some, especially acutely, some potential new weakness. And in this case, it was mild. So now we're going to get into neuromuscular diseases. I think we're doing good on time. Um, so to kind of talk about to before we get into the some like cases of neuromuscular diseases, when we think about neuromuscular processes, we're thinking about like motor neuron diseases like ALS or PLS, uh, which are disorders of the central nervous system, or neuromuscular junction disorders like myasthenia gravis or Lambert-Eaton syndrome, something that would impair the electrical to chemical conversion of those action potentials and muscle firing. And so when we think about specifically when we think about myasthenia gravis, and we'll talk about that in a case in a second, that disease process, essentially what it is, it's like the again like a abnormal hyperimmune response where the body produces antibodies that prevent that acetylcholine from binding. So that what we see is if those muscles in that neuromuscular junction can't get that acetylcholine to the muscles to activate and fire, what we see clinically is weakness. Peripheral neuropathy, such as let's think like Guillain-Barré or CIDP, chronic inflammatory demyelinating polyneuropathy. So potentially more damage to the actual the nerves outside of the central nervous system. So maybe the signals, if there's damage, like something in like Guillain-Barré, if there's damage to the myelin that covers and surrounds the axons, if that myelin's damaged, then those you can't the muscles can't get that message. It's very inefficient. So then we see weakness there. Or perhaps something like in our head and neck cancer patients, I've seen like cranial neuropathy as a result of radiation, so or surgical intervention. So if the hypoglossal nerve, for example, if there's injury, radiation induced injury or surgical induced nerve injury, then that nerve can't communicate with the muscle. And I saw recently somebody who had base of tongue cancer, and he'd had lots of treatment, but he had radiation and surgical intervention. And during the cranial nerve exam, when I had him stick his tongue out, it was deviating to the affected side, and there were also fasciculations because that lower motor neuron signs because that nerve was damaged. Myopathies, so damage at the level of the actual muscle fiber. So things like myositis, polymyositis, there's like mitochondrial myopathies. In particular, like I've seen inclusion body myositis where the muscle fibers have these little inclusions in them, and that damages the actual muscle itself. Very interesting and very unique presentation in terms of dysphagia. So when we think about what is our primary role, I mean, in general, of course, this should always be specific to the disorder, the disease process itself. But in general, what's our role when we think about like neuromuscular diseases? Mostly, for the most part, if I'm going to do like a blanket statement, primarily compensation, education, and conservation of function. Because we think about like cortical injuries, like a cortical stroke or a subcortical stroke, or sometimes even brainstem strokes. We have neuroplasticity on our side. We have the the innate ability for the cortex to kind of rewire itself, like high intensity repetitions, behavioral dysphagia therapy, because you can recruit that neighboring like healthy brain tissue to kind of take over functions of the damage or the infarcted tissue. But you don't have that when we think about neuroplasticity. We don't really have that on our side in terms of neuromuscular diseases. So for example, exercise can't rewire a muscle fiber that's physically degenerating. It can't it won't fix a structural deficit in a muscle cell's protein, and it certainly won't force a nerve to remyelinate. So, in cases of neuromuscular diseases, and we'll get again into a case in a second, but really our role might more be so compensation in terms of swallowing, like swallowing strategies, maneuvers, things that might increase swallow safety or efficiency, diet texture modifications, risk management, education, oral care, mobility, all that stuff. And maybe some conservation, like energy conservation, so that we're not overworking and exhausting the swallow system. So, on that note, thinking about like the overwork weakness kind of theory, um, the idea behind this is, for many of these neuromuscular processes, if you push a diseased muscle too hard, or you tax a system like in myasthenia gravis, where it's not a cortical issue. We don't have neuroplasticity really on our side. You can actually accelerate some of this damage, like in cases like in ALS. We're not doing intensive, high intensity repetition dysphagia therapy because that can actually accelerate degeneration of the motor neurons and kind of that like cell death. So it's really important to know, in what process could I potentially be overworking and exhausting the motor unit to the point where I might do more damage than good. And we'll talk about that in a clinical example now. So our case application for our neuromuscular disease is a patient with known myasthenia gravis. He was admitted with acute dysarthria, bilateral ptosis, so bilateral eye drooping, and as a result of that, had double vision, sudden onset of dysphagia, and the medical team is treating the patient for a presumed myasthenia gravis exacerbation. His last myasthenia gravis exacerbation was 2 years ago following a cardiac procedure, so a time that the body was under quite amount of physical stress that may have kind of prompted that hyperimmune response to lead to a like exacerbation or a crisis. He's on Mestinon 3 times a day. We often see that patients with myasthenia gravis are on Mestinon because essentially what it does is it kind of slows down the breakdown of acetylcholine so it can kind of stay in that neuromuscular junction longer. The SLP was consulted for speech and swallowing evaluation. He's NPO pending our evaluation. And importantly, he has not had his Mestinon for nearly 24 hours because he's NPO. And this is where this patient was in the ICU, and I looked at the APP in the ICU. I said, "Get this man his Mestinon." I don't know how you do it. We can, the benefits of the Mestinon in his system will outweigh the risks of potentially maybe aspirating it crushed in liquid or applesauce. His per the chart. So before I even saw him, his symptoms were really isolated to his bulbar muscles. He didn't have any extremity weakness, or he hadn't yet. He was, what brought him in was his this abrupt onset of this very hypernasal speech. He had a really hard time moving his mouth, his articulators, and of course his swallowing. And then looking at the respiratory therapy note, his last NIF, or his negative inspiratory force, something that they should always be tracking in our myasthenia gravis patients, was negative 38. And so not terrible, but not good. NIFs are like kind of like a maximum inspiratory pressure, or kind of think about it as like a MIP. Essentially the amount of negative pressure that's in the thoracic cavity when you take an inspiration, when you inhale. For a normal, like healthy system, it would be anywhere from like negative 75 to like negative 120, negative 125. And his was negative 38. So what does that mean when we're thinking of what is a less negative NIF mean? So we want a better NIF would be a more negative NIF. So what are the implications of a less negative NIF? Maybe that ability to pulmonary clearance. Like if he can't get that good inhale, and potentially if he had like an aspiration event, it wouldn't be able to clear that like from a pulmonary clearance or pulmonary toileting standpoint, or subglottic pressure. We know that swallowing is a pressure driven system, and so if the NIF is poor and he can't get that subglottic pressure to kind of help close off those vocal cords and have that protection of the airway, potentially more susceptible to aspiration. So my clinical swallow evaluation, patient seen the state for a clinical swallow eval, admitted with dysarthria, ptosis, diplopia, sudden onset dysphagia. He's oxygenating well despite his abnormal NIFs. When I saw him, he was on 2 liters of oxygen, and the medical team just said that was kind of supportive. Like, just he wasn't having any like respiratory distress or respiratory symptoms like hypoxia or anything. It was more supportive because of the potential for a significant rapid decline in his respiratory muscles. Ongoing bilateral ptosis, mild flaccid dysarthria. He told me that things were getting stuck when he was swallowing. He said he couldn't chew. He said, yesterday I tried to eat a donut. I couldn't chew it and I felt like I was choking. He received 1 session of IVIG. So that's the intravenous immunoglobulin therapy. So essentially, one of the primary treatments that neurologists recommend when somebody's in a presumed neuromuscular or a myasthenic exacerbation or crisis. And there was a plan for at least 5 more. He had not received his mestinon again, so requested the medical team provide that immediately to optimize his speech and swallowing. When I saw him, his cranial nerve exam was abnormal, concerning for involvement of cranial nerves 5, 7, 9, 10, and 12. So consistent with that neuromuscular kind of diffuse bulbar involvement. But interestingly, his laryngeal function exam was normal. I mean, his voice was strong, like his vocal quality, his volume, his pitch, everything was normal. His maximum phonation time, 28 seconds, and in acute care, that is good. With limited PO trials, appreciated some signs of oral and pharyngeal dysphagia. He said, again, it was like difficult to like move the tongue. He felt like he couldn't really like manipulate food. He talked about that globus sensation, need for multiple swallows. He said, maybe I have like since yesterday noticed some more coughing like after I drank. This is a perfectly cognitively intact patient, so that's always very helpful when they're a good historian. So we talked about doing a modified barium swallow study to objectively look at his swallow function, his airway protection, his pharyngeal clearance, and kind of guide our management. And so I had said, this is planned for today after his mestinon has been given. So he said, pending the modified, recommend that he's NPO, accept some ice chips after oral care, critical meds like the mestinon, crushed and puree after oral care, and we'll do this modified once he's got that mestinon in his system and we've optimized his swallow. His modified barium swallow study revealed moderate oropharyngeal dysphagia. The digest score was S0, safety 0, and E, efficiency 3. So based on that score, it kind of highlights already that his swallow was safe. It was just very inefficient. So it was primarily characterized by slowed lingual movement, reduced base of tongue retraction. This led to pretty significant reduced driving force of the bolus through the hypopharynx and nearly absent pharyngeal stripping. And so these deficits led to impaired pharyngeal clearance or swallow efficiency. He needed to swallow 2 or 4 times to clear the majority of the bolus through his pharynx. But his swallow safety, his prandial airway protection was really intact. So we saw some flash kind of clearing penetration. So PENAS score of 2, which is considered within normal limits. His oral, laryngeal, pharyngeal sensation really were excellent based on what he was telling me. Like during the study, this is where I feel it. I feel like I need to do X, Y, Z. And you would expect that with a purely motor process like myasthenia gravis. Solids were not given because of the inability for him to close his jaw and masticate. I mean, it was literally like this, like it was like locked. He was like, he kind of, and so due to difficulty with full mandibular closure and mastication, oral weakness, and reduced oropharyngeal clearance of solids, patient is at an increased risk for airway obstruction or choking with solids. So recommend initiation of pureed solids a thin liquid diet with swallow guidelines in place. So taking breaks if feeling fatigued, because we know in myasthenia gravis there's a risk for like rapid use of the acetylcholine that is there in that junction. And so we can see, maybe somebody starts off fine, and then as they continue to use those muscles and kind of tax the system, they fatigue. And then I also said that suspect that with medical or pharmacologic treatment of his myasthenia gravis, like with the IVIG, this will likely improve. And then due to the nature of the neuromuscular disorder, exercise-based rehab is not indicated. And so our management will primarily involve temporary modification of this diet, compensatory strategy training. And then I also mentioned, if there is because with myasthenia gravis, they can look fine one day and then they can have an absolute deterioration of symptoms. So if there's a decline in his voice or his respiratory function, recommend that the medical team notify the SLP team, because then we might be concerned for decline in his airway protection with swallowing. And then, of course, recommend that his Mestinon, his myasthenia gravis medications are timed within about an hour of meals to kind of optimize swallow function. That's ultimately up to the neurologist and the medical team, but I've never gotten pushback from our medical teams because it makes sense. If you want to optimize swallowing, you have to make sure that the potential medical pieces that could help are in the system. So his modified barium swallow study, in the first picture, you can see pharyngeal residue following his initial teaspoon thin liquid. So it doesn't look like too concerning, but you also have to keep in mind this is a teaspoon of liquid, so 5 ml of liquid. And that was the kind of the pharyngeal residue after that initial swallow. And in the second picture, you can see that lingual kind of on his posterior tongue surface and the follicular residue following the initial swallow of a teaspoon of pudding. I mean, it was like the majority of what he had, but he said, "Oh no, I feel it," and then he kept swallowing, and with several serial swallows, it did improve. And then in that last picture, you can see that his airway protection is intact despite these bilateral physiologic impairments. He is protecting his airway. His laryngeal function is good, which is always a good thing in myasthenia gravis if their respiratory system is involved and their potential to potentially clear any aspiration is compromised. So to kind of end things off, we got a few more slides here. I talk about making kind of like hypotheses to guide our decision making, and this is from the lens of acute care, but you can apply this to any setting with any population. Let's say that somebody comes in with a left central lower facial droop and left upper extremity weakness. We'd probably be concerned, or I'd probably start thinking about potential right cortical or subcortical involvement. And so I might be prepared to assess speech, swallowing, and cognitive communication, like maybe there's left inattention. And that's all with the assumption that that's that presentation. I mean, there's always a caveat of you can walk into somebody's room and it might be a completely different presentation than what you're expecting. So you might have to modify things, but kind of having that potential presentation in the back of your mind so you kind of know what you might expect. And another example, patient admitted with a hemifacial right-sided droop and left extremity weakness, but no cognitive impairment. So might be concerned here for pathology localized to the brainstem, the pons, because of this crossed hemiparesis presentation. So I might be prepared more to assess like motor functions like speech and swallowing, and maybe less focus on cognitive communication. And then the last one, patient was admitted with progressive dysphagia over several months, bilateral ptosis, nutritional compromise like weight loss, all of that, kind of that constellation of symptoms maybe could indicate possibly a neuromuscular process. And so ensuring that the right people are involved, like neurology. And like I said, you can prepare as much as you want, and sometimes you walk in the room and you're like, what is this? So always be able to modify what you were thinking, because we talked about the patient whose chart said aphasia, like it might not be accurate. Some people come in with aphasia and the notes say altered mental status. And so you just have to kind of be flexible in what your plan for assessment is. All right, this is our last slide here. So I've talked a lot about why knowing the diagnosis matters. For obvious reasons, it matters. But I did have a patient when I was a clinical fellow. I did my clinical fellowship in inpatient rehab. It was an acquired brain injury unit, but we also saw like neurologic disorders like Parkinson's, etc. And I had a patient. I will always remember him. Um, he was diagnosed with Parkinson's like a few years prior to this admission to rehab. He had had a modified barium swallow study at our like sister acute care hospital, um, which had revealed moderate oral pharyngeal dysphagia, and they had recommended, starting some intensive exercise-based intervention. And this was a relatively early on in his Parkinson's diagnosis. And Parkinson's is, yes, it's a progressive neurologic condition, but it's one of the ones where, especially earlier on in the process is responsive to behavioral like intervention like exercise. So what we did and to kind of for dysphagia intervention was several exercise kind of based interventions that targeted the deficits that they had seen on the modified barium swallow study. I don't remember the specific ones, but I know that we were using like effortful swallow paired with a bolus, and to kind of challenge the system, we'd increase the size or the viscosity. And I remember I was so proud of him because one day, in inpatient rehab, you see them every day for like an hour. So one day we'd do, 60 repetitions. And the next day I'd challenge him more and we got to 80. And I remember talking about him with the medical team being like, oh, he's doing so good. Like he's so motivated. He's doing all the exercises. He asked me for feedback. And it was like probably like a week and a half in. And I was talking to the physical therapist one day, and he was like, he's really not, he might actually be getting weaker, worse. And I was like, oh, really? Like, what do you mean? And he said, like he's needing more assistance than he did initially when he got in. Like he should be going the opposite direction, right? He said he also mentioned like whenever he was getting him up from the bed or the wheelchair, that he'd get really orthostatic. So his hypotension, get hypotensive, and his blood pressure would just plummet. And what I thought was interesting was I noticed when we were doing the swallow exercises, I'd intermittently like put a pulse ox on him just to check like his oxygenation. I think when we were doing like PO trials and stuff, it's not necessary, but I had it. And I noticed that it would drop to like, when we're doing like effortful swallow or effortful pitch glides, like those were some of the things that we were doing. It would drop to like the 80s. And I was like, interesting. So it was having these like very autonomic kind of issues, respiratory rate, oxygenation, blood pressure. And I also noticed too that his cranial nerve exam, his kind of the overall presentation of his like motor function, which is not, it didn't paint the picture of what we see in Parkinson's. It wasn't like a hypokinetic dysarthria. It wasn't like the masked facial expression. He was like drooling. He had some like spastic vocal qualities sometimes. I don't remember the specifics of what I noticed, but I did know that his cranial nerve exam was not consistent with what you might see in like a Parkinson's disease only process. And then the last thing that kind of put the nail in the coffin was I don't know if the patient or one of the medical team members had said he's been on levodopa or Sinemet for since he got diagnosed, and initially it worked a little bit, but now it's not having any benefit. He's not benefiting. It's not helping his motor function. It's not helping what we would expect it to help in Parkinson's. And so the physical therapist, me, and at the time we had a neuropsychiatrist that was in rehab, which was excellent. And then the neurologist that had initially seen him in acute care kind of like put our heads together and we're like, this doesn't feel like Parkinson's. And the diagnosis was actually changed to multiple systems atrophy. And so that kind of explained why with this intensive, high intensity, high repetition rehab program, he really only declined. and we were taxing his system. We were overworking his system in a process that um, was, in multiple systems atrophy. You've got degeneration of the basal ganglia, the cerebellum, the cortex, the brainstem. You've got a lot of essentially just like degeneration, and so that was an example of where it's really, really useful to know what you're working with because you could potentially do more harm. Um, and so what happened with this patient, he ultimately, after that kind of that shift in diagnosis and the whole goals of care kind of shifted, he went comfort care and he did end up passing away shortly after. But one of those examples of why it's really important to know what you're working with. So takeaways here. Many neurologic diseases present with speech, voice, cognition, and swallowing impairment, and our involvement is vital. And I think it's Dr. Duffy that said this, but a lot of neurogenic disorders, one of the first symptoms in a lot of them is dysarthria. And so we might be one of those people that has more of a keen eye to tune into some of the kind of those bulbar symptoms. And we can really play an important role here in the next point in differential diagnosis so that, our assessment, our cranial sensory motor exam, if you want to call it that, can really help guide kind of teasing apart differential diagnosis. Understanding cortical signs can guide our assessment tests. So, aphasia, agraphia, neglect, kind of things that what if we're hypothesizing that somebody had a cortical stroke, what assessment test might we be prepared to give? And then lastly, the same physiologic swallowing deficits that are identified on imaging might be managed completely differently depending on the neurogenic etiology. If somebody has myasthenia gravis and has dysphagia as a result of that, that's going to be managed very differently than somebody in terms of rehab, somebody that may have had a cortical stroke and could potentially benefit from high intensity exercise training. So lots of things to kind of soak in. I guess I'll end it there with questions. So wow, thank you for letting me just yap on about the brain. I love doing it.
It was amazing. A couple of quick wrap up comments, and then we'll dive into Q&A. If you are interested in obtaining ASHA CEUs for this webinar, like I mentioned at the beginning, just fill out our brief survey. I put it in the chat. It will also be sent out via Zoom email, as will Anna's handout. And then if you're on a mobile phone and you can't access that, like I said, it'll be sent out via email, and then the handout will also be available on the TIMS website, which the replay should be up within 48 hours with that handout. So if you have any questions about any of this information, just send us an email at tims-univ@tims.com and we can get that to you as well as your certificates of completion. So with that, let's dive into Q&A because we have some great questions. Okay, I thought this one was pretty interesting because I have heard about this pattern and seen this as well in my practice. So this person said, curious about your thoughts on the push for physicians to forego MRI brain and only diagnose stroke based on clinical presentation since initial admit CT is often negative for acute process. I've been seeing our acute care physicians write in their notes that MRI brain almost never changes clinical care plan, but I feel it's so important as an SLP to know more specifically what parts of the brain have been impacted to know what types of deficits we can expect to evaluate and treat.
Lots to unpack there. So usually, when I've talked to physicians or people like neurologists, I love to ask questions and I love to learn. And so actually I've asked a radiologist recently. I had a question about swallow study. I was like, hey, can you just give me can you chime in about this too? Usually what he said was when somebody comes with stroke symptoms, the CT, we know that the CT, even with when we look for sequela of aspiration, we know that chest CTs are preferred over chest x-rays. They're more detailed, there's a lot more images, they're more fine. CT though, when we think about the brain, the CT is kind of more of a quick screen, whereas the MRI is a lot more sensitive. It's kind of like the chest x-ray and the chest CT for chest imaging. The CT head is more to kind of quickly screen, rule out things that might be more emergent, like a bleed, that might require like neurosurgical intervention or that might be a contraindication to something like TPA or TNK. Whereas an MRI is, I mean, where I am, I'd say that where, and if there's concern for a stroke, they do CT head initially to rule the things out that would be contraindications or require emergent intervention, with always also ordering an MRI to follow up. Because I've also heard the neurologist talk to patients and say, you know, the management that I recommend might change depending on the size, the nature, the location. It's we can't answer the full clinical question about what's the most optimal management. When we think about like antiplatelets and anticoagulants and all that stuff about dosing, that might vary depending on the details they get from an MRI. So I would say, I'm not a neurologist, but I would say that optimally, if there's a concern for an acute stroke, you should absolutely be getting an MRI too. And I think that's best practice.
The next question is it possible for stimulation of the sensory branches of cranial nerves, such as the glossopharyngeal or vagus, to improve motor function?
Um, is this in like as a potential dysphagia intervention,
I'm assuming that's all
like
that they
electrical
said.
stimulation? I don't know. I'll be honest. I don't know if there's much evidence to support. Um, I mean, we know a lot like the sensory motor system, sensory function drives motor output, et cetera. But I don't know if there's much to support in terms of like rehab and intervention. And I also don't know the method of which you'd be stimulating the nerves. I mean, I know there's a lot coming out about like pharyngeal um, stimulation and manometry and stuff, but we don't really have much of it yet in the U.S. Um, but that's something that we could research. So I don't really know, but I don't think there's a whole, in terms of like neuromuscular stimulation or neuroelectrical stimulation, like you know, e-stem, etc. Um, there's some evidence to support that, but it's usually more so in like cortical injuries, like cortical strokes. But I don't do it, so I don't think I can like really answer that question. But it's a good question. I don't know.
Um, Jocelyn had a question specific about one of your cases. In the case where it was written that the patient had aphasia and you determined that that was inaccurate, um, she wanted to know how you documented your findings in the case, in that specific case, and whether or not you commented on the previous diagnosis of aphasia.
I don't think I commented on like in I don't remember exactly, but whatever I said, let's go back to it, is what I documented. I said that the patient, where is it? I said this patient is nonverbal due to paralysis, like a motor impairment, not a linguistic impairment. So I documented this patient is anarthric and that he did not have signs and symptoms of aphasia. And then I did talk to he was in the ICU at the time. I talked to the APPs about it, and they weren't the ones that had documented, but they were like, oh, okay, that makes sense. And so they were kind of just saying like, this is good to know, to kind of just, how you interact around the patient and going forward in their chart, what we can be documenting. But that's exactly what I documented.
Awesome. This next question is from Craig, who said, "Thank you for describing the form function dichotomy so well. In your clinical practice, are you using standardized slash norm referenced or more informal criterion reference measures during the acute recovery phase?"
And I don't know if this is pertaining to swallowing or what, but I would say, regardless if it's language, cognition, swallowing, that in acute care, we don't really have we have a little bit more of a time limitation. And the other thing is these patients are just changed so rapidly. They could look one way one day and a different way another day. And they might also have exacerbating factors like pain and delirium and, you know, sleep and all the other things that can influence that kind of acute phase. So I don't, not just because I don't think that it would be a very reliable measure in that phase of recovery, and because I don't have the time to do like batteries. But I will do mostly informal measures. But of course, I kind of guide it. Like I said, if I'm hypothesizing that somebody might have an aphasia because they came in with like a lateralized right-sided weakness and trouble communicating, I might do a comprehensive assessment of reading, writing, verbal expression, and auditory comprehension. I might look at all those things. Whereas if somebody comes in with signs and symptoms or of more of like a cognitive impairment, or I might look for like neglect or something like that. But I'm definitely doing like a combination of informal things.
So, just in respect of everyone's time, we'll just end with one final question. But I know there were a few more, so I'll make sure I copy and paste those and send those to Anna as well. So this last question is, in the case where you showed the fees images,
Mhm.
how did you visualize unilateral UES opening? The person said, I assume, or I am assuming that you inferred this based on the neuro diagnosis.
Um, I inferred it based on the location of the residue. Yeah. Um, and yeah, let's go back and look at the picture. So the scope is kind of like at a weird angle, but you can see that in that first image that the residue, like if you think about where like the post-cricoid space and the upper esophageal sphincter are, that it was consistently like this, and that when he had things that are a little bit more like viscous or heavier, that residue would lateralize to that one side. So I was inferring it. Yeah, with fees, you're making a lot of inferences because of things like the whiteout and the inability to kind of see like the actual um, middle or during the swallow. But again, fees is helpful in that maybe we might be able to see more of that lateralized residue, whereas in a modified barium swallow study, you don't really get that benefit.
Awesome. Well, Anna, thank you so much for your time this evening. This presentation was incredible, and thank you all for joining us this evening. If you have questions specifically for Anna, her email address is here up on the screen. And like I said, the replay for this will be up on the TIMS website within 48 hours. But if you have questions for us in the meantime, send us an email at tims-univ@tims.com. And with that, we will see you all hopefully next week. Thanks so much, Anna.
Thank you. Have a good
Bye,
night.
everybody.